The stage one of the meaningful use required no actual cross-platform exchange of information. Stage two requires one instance of information sharing, and that can be with the dummy server set up by the government. In 2013, how is it possible to meaningfully use information technology without actually sharing information outside of a proprietary network? And so the question really is, hasn't the bar really been set too low for those who are ready for an advanced level of exchange?
We do have, I think, again, listening to the community and everybody who's affected by this, including some rural providers who said that they don't have means of exchanging information. I think the challenge that you raised is exactly right. How do we not hold back those who want to be the trailblazers and yet make accommodations for the diversity that we have in our country? The other observation that we've had with setting thresholds, Senator, is we fight a lot and have a lot of discussions about what the threshold should be. And what we actually find is that when the data comes in, when the providers actually do the workflow changes, they don't just do it for 10% or 20% or 30% of their patients. They do it consistently. And there was just a paper published this week that found that whatever the threshold was, the actual median level of accomplishment was between 92 and 100% on the part of hospitals in the threshold. So for me, one of the lessons has been to focus a little bit less on fighting over the threshold and just get folks to begin making that transition. I think the menu items, the menu optional approach was one way that we allowed for people in stage one who are ahead to get credit for information exchange use. And for stage two, we said, you know, it's now everybody has got to be able to do it. I'd love to continue to work with you and with the committee on how we can continue to keep the pressure on interoperability and care coordination while accommodating the diversity we have in our country.
In the stage three rules have not been written, and I'm wondering how we achieve those goals that you've laid out between now and the end of stage three in a reasonable way, and I'm also wondering what your plans are for after stage three. Are you planning future stages? If so, what do those stages look like?
Maybe I'll start, and then Dr. Mostashari can build on. We plan to write the stage three rule in 2014. To the previous question on interoperability, we put out a request for information on how we push interoperability forward. And so we're taking that input in both for stage three rulemaking and for any other changes outside of meaningful use rulemaking. So we plan to propose stage three in 2014.
Okay.
In terms of the roadmap for meaningful use, I think I was just visiting Virginia Commonwealth University last week with Patrick and John Blum, and their journey is very similar, I think, to what many other providers are facing, where their first priority was making sure that within their practice, within their hospitals, all across their different sites and specialties, they can share the information and the information is available when they need it. That's kind of stage one. And that was their first priority, the first few years of their journey. The next priority for them was, okay, now how do we reach out to our affiliated providers that we work closely with all the time? How do we make sure those referrals get to them, get back and forth, the laboratory results are getting where they need to go, the EKG results are going where they need to go? That's stage two. And much of what we have in place will support that sort of local coordination of care, planned care, referral exchange, laboratory exchange, public health exchange, pharmacy exchange, the network of providers that are within your local community that you exchange information with. And for stage three, and where they're not quite there yet, is how do I allow someone else to query my system? And there are lots of concerns that providers have before allowing that to happen. They're technical issues, but they're also issues of how do I know that you're authorized to do this query? How do I know that you're getting at the right patient? What if I release information on the wrong patient? How do I know to trust you? So those are, I think, if we look at the roadmap for how we're going in interoperability, the goal is always the same. The goal is that patient information is available when and where it's needed, but the staged approach accounts for the realities of where we are and where individual providers will be in their progression. First, let me get my own house in order. Next, let me exchange information with those I talk to all the time in my local community. And then the next stage will be enabling that, what we all hope for, that wherever we are, if we have a problem, that our information can be accessed. I will say that the other thing that Stage 2 permits is this. Stage 2 permits every patient, every family member, every caregiver who chooses to accept more responsibility and be empowered with their own information to get their own information and share it with whoever they want to share it with. And I believe this is going to be a major step forward if healthcare providers also embrace that relationship, new relationship with the patient.
Good. Thank you, Mr. Chairman.
Yep, thank you.
Gentlemen.
Yeah, what happens there, someone that tries to access John Smith's record with their 1 million John Smiths?
Yes.
How do you handle that?
So that is one of the barriers towards enabling the sort of exchange that we hope to see, right, is if we're in a local network, if a patient is, I was in Metro Health in Cleveland, and I saw a patient sitting next to a doctor who said, I got my care at Cleveland Clinic. And they went and they queried Cleveland Clinic, and they got the patient's records back because it wasn't a query to the world asking, does anyone have information on the patient? The patient told them, it's a Cleveland Clinic. So they only asked Cleveland Clinic, and the universe of potential wrong matches is dramatically lower if you know who you're asking and they know who you're responding to.
And if you don't,
If you don't, it's much more challenging.
the solution?
We're going to continue to work on finding ways to improve the quality of patient matching, improve the data quality that's used to do that matching, and have guidance on what constitutes an adequate match and what are the liability, frankly, issues and protections in the case of incorrect matches.
So how you building trust? You mentioned some providers may not want to divulge information. They don't know if it's going to go. They can trust the person making the query.
Correct.
How do you develop trust?
So trust builds up, I think, over time in the people that you work with in sharing care for patients. That's the first name basis trust. But we can also create institutional supports for that trust. So one of the things that we are funding and working with are governance entities that can say, let's all agree to a common set of rules of the road in terms of how we treat patient information, how we authenticate the users, whether we get patient consent and how. And having different organizations that follow the same rules of the road can increase that trust. But it's no substitute for actual experience.
Yeah.
And
Yeah, I'm not